Welcome back. Today's focus is the backbone of community-based nutrition and early childhood services in India, Integrated Child Development Services or ICDS. Dr. Joshi, could you start with a crisp exam definition?
ICDS is a community-based program delivering a package of services to children from birth to 6 years, pregnant women and lactating mothers through Anganwadi centers. The aim is to improve survival, growth and development by integrating health, nutrition and early learning at neighborhood level. Do remember, ICDS falls under Ministry of Women and Child Development, more WCD, and not under the Ministry of Health and Family Welfare.
Pause and recall. Who are the beneficiaries? Correct. Children 0 to 6 years, pregnant women and lactating mothers, plus adolescents in selected interventions. Dr. Joshi, what exactly is the package of services students must list in exams?
The classic 6 are 1. Supplementary nutrition, 2. Growth monitoring and promotion, 3. Preschool non-formal education for 3 to 6 years, 4. Health checkup, 5. Immunization, and 6. Referral services. Add a 7th cross-cutting element, nutrition and health education for caregivers. The Anganwadi worker leads delivery, supported by the Anganwadi helper with convergence from the health system for immunization, antenatal care, deworming and vitamin A.
To make this practical, could you map who does what at the Anganwadi?
Think in 3 parts: center-based services, doorstep services, and supportive supervision. At the center, the Anganwadi worker counsels families, maintains growth charts, runs preschool sessions, and manages supplementary nutrition. The helper cooks, serves, maintains cleanliness, and mobilizes beneficiaries. Caregivers bring children regularly, participate in weighing, and attend counseling or demonstrations. At the doorstep, the worker conducts home visits, tracks growth faltering, and reinforces feeding and care practices. The A&M and ASHA visit for antenatal care and postnatal care, immunization follow-up, and basic screening. For supervision, the Mukhya Sevika mentors several centers. She reviews registers, guides problem-solving, ensures service quality, and strengthens community linkages. The PHC medical officer anchors clinical support and referrals.
Students often get confused about the nutrition component. Could you outline the logic without drowning in numbers?
Think who gets what, when, and why. For children 6 to 36 months and for pregnant or lactating women, take-home rations, fortified mixes, or ready-to-eat items fit household feeding practices. For children 3 to 6 years, attending the center, a hot-cooked meal supports energy, protein, and micronutrients during active play hours. Purpose: bridge dietary gaps, promote regular growth monitoring, and keep families engaged with health checks and counseling.
Case Vignette 1. A 2-year-old girl Meera is brought to the Anganwadi. Her weight for age line has flattened. Mid-upper arm circumference, MUAC, is 11.2 centimeters. What should the team do and how does ICDS coordinate with health services?
First, classify. MUAC less than 11.5 centimeters suggests severe acute malnutrition. The worker should 1. Flag the growth chart and counsel on frequent energy-dense feeds. 2. Immediately refer Meera to the PHC or a nutrition facility for medical assessment and screening for complications. 3. Coordinate with the A&M for deworming if due, iron folate where appropriate, and any missed immunizations. 4. Ensure weekly follow-up and appetite checks. If complications exist, fever, edema, or persistent poor appetite, urgent referral is non-negotiable. Back at the center, document progress, demonstrate feeding, and troubleshoot home barriers.
Analyze the gaps. In real life, where do Anganwadis stumble in such a case?
Pitfalls include delayed detection due to missed weighing days, poor plotting quality, supply interruptions in take-home rations, weak supervision, and poor two-way referral communication. Solutions: schedule weighing with community reminders, on-the-spot counseling using the Mother and Child Protection Card, color-coded MUAC tapes for quick classification, supportive supervision, and a referral slip with counter-signature on return to close the loop.
Dr. Joshi, a quick structure for a 10-marker on ICDS?
Use rational, beneficiaries, services, platform, intersectoral coordination, monitoring, challenges, way forward. 1 paragraph each shows logic from determinants to delivery to outcomes and quality improvement.
Case Vignette 2 for adolescent nutrition. A 15-year-old girl, Rani, attends a village health and nutrition day with her mother. She reports fatigue, school absenteeism, and a low body mass index (BMI) for age. How should the Anganwadi and health teams collaborate?
Start with screening. Check hemoglobin if available, menstrual history, dietary recall, and deworming status. The A&M provides iron folic acid via school or community supplementation and deworms if due. The worker counsels on balanced diet using local foods, addresses myths about menstruation and sports, and explores social barriers like household workload. Red flags, severe pallor, syncope, or suspected pregnancy warrant PHC referral. Document and follow up monthly, linking Rani to school health sessions and peer groups to sustain behavior change.
Students also need monitoring tools at their fingertips. What records matter most at the Anganwadi?
3 essentials. 1. Growth monitoring charts for every child plus a consolidated center register. 2. The mother and child protection card with growth, immunization, counseling points and danger signs. 3. Monthly reporting into block and district dashboards on supplies, attendance and nutrition outcomes. Many states now support digital tools, for example the Poshan Tracker app, to regularly monitor beneficiaries' nutritional status and attendance.
Intersectoral coordination, examiners love the term, but expect specifics. What are the practical convergence points?
With health, immunization, vitamin A, deworming, antenatal care and postnatal care, high-risk referrals, and infant and young child feeding counseling. With education, school readiness and smooth transition to grade 1. With water, sanitation and hygiene, hand-washing stations, safe water storage and toilets. With local governance, village health, sanitation and nutrition committee funds for minor repairs and behavior change events. Convergence works when there is a shared microplan, joint monthly review and co-located village health and nutrition days at or near the Anganwadi.
Evaluate with a management lens. You are a block program manager and hot-cooked meals are irregular at 15% of centers. What steps will you prioritize in the first month?
Diagnose and fix across 3 lanes. Supply, verify ration delivery cycles, buffer stocks and storage, unblock vendor or transport issues. Process, standardize morning checklists, mealtime rosters, and food safety steps. Coach the worker helper team on site. Community, activate mothers groups to taste test and rate menus, display weekly menus publicly, and use a simple meals served today tick board. Close the loop with weekly monitoring calls and a rapid audit of meal temperatures, serving time and hygiene.
Pause and recall. What are the 6 classic services of ICDS and which 2 rely most on convergence? Now challenges. Please keep it exam-focused but not bleak.
Key challenges are variable infrastructure, interruptions in nutrition supplies, under-detection of growth faltering, uneven preschool quality, and documentation overload. The way forward, strengthen training with hands-on mentoring, ensure predictable financing and last-mile supplies, modernize growth monitoring with color-banded MUAC and length boards, enrich play materials with local resource kits, and build a culture of supportive supervision rather than fault-finding.
A quick do and remember list for Viva?
Do, greet the caregiver, review the growth chart first, and ask about the last home visit. Demonstrate one feeding or play activity while counseling. Record immediately after the session. Align advice with what the family can afford and cook. Always close with a specific next step. I will see you next Tuesday at the weighing session.
Before we close, can you give students a memory scaffold to reproduce in exams?
Use NEST, nutrition, education, screening, and tie-ups. Under nutrition, take-home rations, hot-cooked meals in counseling. Under education, play-based preschool and school readiness. Under screening, growth charts, MUAC, anemia checks, and referrals. Under tie-ups, health for immunization and antenatal care, education for transition, water sanitation for hygiene, and local governance for center upkeep.
Lovely. Final lightning round. 2 red flags demanding immediate referral from an Anganwadi?
1. Severe acute malnutrition with complications or bilateral pedal edema. 2. Any child with persistent fever, convulsions, or severe respiratory distress. Do not wait, stabilize and refer with a note to the PHC.
And 1 line to wrap it up for the Viva, Dr. Joshi.
An Anganwadi is the community classroom and clinic corner rolled into one. When nutrition, play, and timely health links come together, children do not just survive, they thrive.
Quick self-check before you move on. Pause and recall. State the beneficiaries, the NEST scaffold, 2 convergence actions, and 1 improvement you would implement in your first month of posting. That's your ICDS answer. Clear, structured, and exam ready.